Our hope today is to try and pull together some of the thoughts of the room and some of the thoughts of our expert panel about treatment of the left main bifurcation. So last year, we for the first time tried to get together a consensus meeting looking at treatment of bifurcation. This format of the session was to look at the EBC position as it currently stands in the guidelines. For two presentations, one pro, one contra, then some discussion around the table, and then to try and draw it together. And what we'll try and do today is some voting using the app that you've got on your phone. So why does the EBC exist? Well, there are a number of reasons. It's a nice weekend away, it's nice to meet some friends, it's nice to have a nice dinner. But ultimately, one of the key messages, one of the key reasons all of you have sacrificed your time to come here is to talk about what's the best bifurcation technique for the majority of operators performing the majority of cases. One of the problems of expert panels is that in an expert community, there'll always be someone who says there's an exception to the rule. If it always goes right, there'll always be someone who can remember one time it went left. But the panel here, the organization, the whole point of a consensus is to try and guide everybody in the community what is usually the right thing to do, not to allow that minority opinion to sway the whole direction of travel for the consensus. There are very many apples out there, and we shouldn't get distracted by the one pair. Democracy is a great thing, and in England we're very proud of our democracy, and this picture is of the Houses of Commons. Interestingly, there aren't enough chairs for all the MPs to sit down should they all choose to turn up. So clearly, they don't turn up very often, but when they do turn up, the idea that we all state our views and we debate things is a very powerful one. However, in retrospect, sometimes debate is not necessarily the best thing, because sometimes if debate is poorly informed, a decision can be made which in retrospect perhaps was not the best decision. And there's no point then saying, well, we should have talked about it a bit more, and perhaps we should have done things a bit different. So it's very important today that you give your views and that we hear what people have to say. Because actually, if people don't debate carefully, and people don't think carefully, and people don't vote carefully, then something really bad could happen. So we've heard how to vote, you've seen the website address, and what we're going to do now is to present two dilemmas within treatment of the left main, and then there'll be an opportunity to vote using the Slido app. So, first part of this will be Thierry presenting the EBC position on this topic. And Thierry is going to present the current EBC position on 2 stents required for left main with a large diffusely diseased circumflex question mark. Thierry.
Thank you very much. So I will try in the 3 minutes to give you the current EBC position asking to this question, 2 stents required for left main with a large diffusely diseased circumflex. So I think you would agree that it's a true bifurcation lesion. Maybe in the cranial view it's more clear, and this is a spider view, and you can see clearly that access toward the LED maybe will not be very easy. So when we look at the last consensus, the first thing is that a provisional cyber stenting approach is recommended in most cases. Maybe it's not the case for this one. Data from non-randomized studies suggest that the provisional strategy, when feasible, is superior to a 2-stent technique. Because of the T-shape angulation, the T or tap technique is recommended in the majority of double stenting cases for left main. It's very surprising to see that this rule is not followed. And when we look back to the 10 years consensus, we have additional information that the circumflex is almost always considered a major side branch because it's usually big, thus favoring a 2-stent technique in case of significant and extant proximal circumflex disease. FFR may be used for evaluating left main bifurcation lesion in stable patients. And intracoronary imaging may be used for evaluating significance and lesion distribution, and is recommended for sizing of the stent. So now we can ask to Ahmed Sheban to explain why we should use 2 stents in this case.
I think there are some variables regarding left main that should be considered. It is distal left main bifurcation is almost 80% of left main disease. burden of atherosclerotic lesion is large. Involvement of the ostia of both LAD and circ are often there. Disease extension to proximal LAD and circ again. And there is a big diameter mismatch often between left main LAD or left main circ. And side branch is a main vessel in this bifurcation because we know that circumflex is one of the three main vessels and cannot be treated like any side branch, small side branch. So if you are leaving something ischemic on side branch or can compromise the outcome, the clinical outcome, this patient will be coming back again for target lesion revascularization. Keep it open is not enough in these cases. The wider angle of the bifurcation, of course, can also make it more challenging sometimes. Calcification also often present. And we should take in consideration, again, that 2 stents in distal left main bifurcation can reach 40 to 50% of cases done, while in non-bifurcation lesion, it is almost between 15 to 20%. And this is why, because its side branch here is not small. So for me, I think there are some situation that we should consider, we should vote, discuss, and vote whether it is suitable to be for 1 stent or 2 stents. I think, first of all, we'll lift dominance. When you have, you might have prognostic impact if you are leaving something, you are not treating optimally circumflex. Even if it's not that, I mean, not focal disease, but even just more than 10 millimeters length of lesion. This may make the difference when you have big circumflex like this. If you have complex anatomy like this, I think to fix circumflex with only 1 stent is to fix the bifurcation. This bifurcation with single stent is not enough. This patient can come back again, of course, with for target lesion revascularization. Anatomy like this, I think it is absolutely difficult to fix with 1 stent. Here you have, again, diffuse disease on circumflex, large circumflex with very complex anatomy, and I think this should be as intention to treat for 2 stents. When you have access, difficult access with huge, severe calcification like this, it is quite impossible to fix. You should rewire the circ, and you might, after putting your stent in LAD, you might crush the ostium of side branch of circ with the calcification there, because even you cannot remove that much of that calcification. Again, diffuse disease, of course, like this, it's very important circumflex in this case and cannot be left without optimal treatment. And finally, I think when you have suboptimal result following provisional stenting, that means even after treating and correcting that with kissing balloon, but still having FFR positive, I think this, again, should go for a 2nd stent. So just to summarize, I think these are the situations that where 2 stents should be as intention to treat in circumflex. Thank you very much.
So Olivier is going to speak to, we don't need 2 stents, we can manage with a single stent.
Effectively, I will always try to be provisional. But I think the question is difficult because provisional is not a technique. Provisional, as always said Yves Louvard, is a philosophy. That means that you always begin by the main vessel. And this is the philosophy. If you begin and you fix the main vessel, you have got time to see what happened after kissing or after port side and report. And you can choose the technique, if necessary, to stent the 2nd lesion. What I mean is that the side branch, the circumflex in the left main disease, is not always a side branch. It can be the main vessel. And if you have got a short lesion at the osteum of the LAD, for example, you can begin by the main vessel, which is a circumflex, doing fix your main vessel by the stent, doing kissing or opening the side branch, and if necessary, stent the side branch, which is not the circumflex because it's the main. If the circumflex is a side branch, it's different than non-left main bifurcation lesion because it's always bigger, the angle is different, and that may influence also the technique and the long-term follow-up results, and it be more clinical relevant to us, so we have to take care to this vessel. And what we have to keep in mind also is that when the circ, if it's a side branch, is diseased, and if it's the disease, the syntax score is higher. So maybe in some cases with complex strategy for stenting, we have to think about surgery also. And finally, to have an answer to this question, we haven't got any randomized 1 versus 2. It will be in the next future in left main disease with long disease in the side branch. We have got registries. This is the COBIS registry from Dr. Guon. And in COBIS 2, we have got a population, high population of left men, certainly are treated with, certain are treated with 1 stent and 2 with 3 stents. When we look at syntax score, of course it's different. And we look that there is a huge difference in terms of syntax score between the patient treated with 1 stent and 2 stents. So maybe surgery in certain cases is the recommended. And if you look what happened in these cases, in the large majority, of course, it's a through bifurcation lesion treated with 2 stents in daily practice. But what are the results, finally, at long-term follow-up? At 3 years, the results of this registry, COBIS registry, of 800 patients, you can see that in terms of cardiac deaths, there is a huge difference between the 2 stents in left main and 1 stent. We have to think about the safety for our patients. And when you look the stent thrombosis between the two, the hazard ratio is more than 5 in favor of 1 stent in left main. So when you put 2 stents, that depends on the technique also, but you have to think about the long-term results and the final result in terms of mortality at 3 years, it's sometimes high. And of course, the target, the TLR is also more important in 2 stents in this registry. Last question is what technique you can apply. There is no difference, but it is not the same population, but in terms of 1 stent and 2 stent in this registry. But if you look the discrepancy of the results causing by the technique, we can add a reflection in terms of simplify the technique for left main disease, and particularly when you have to put a second stent. Remember the syntax trial. It's an old slide, but if you look in syntax, the recommended technique was a provisional stenting. A lot of patients, some patients, had 2 stents, and the majority had the T-stenting technique. And the long-term follow-up is better with the T-stenting technique. But beginning by the provisional approach, stenting the main vessel first, this is very important also. And to finish, I think that maybe angiography is not the good way to prove that it's a 1-1-1 lesion. And I think we should care more frequently with FFR in terms of bifurcation. And there is a DCA Crush 6 study from Dr. Chen, and you can see that no difference in randomization between angio-guided and FFR-guided, but you can see that there's much less 2 stents in the bifurcation when you do FFR before. Maybe that influence the results. So it's a difficult question, difficult to answer. evidence-based are missing in left main 1 or 2 stents in bifurcation systematically. But I think with the real question with the large diffuse disease, we have to think about surgery, and maybe we need a FFR-guided study to randomize and in randomization to ask this to answer this question. Thank you.
Thank you, Olivier. That was perfect, actually. So what this question is about is not so much about when the circumflex looks like it's going to block, do I need to put a second stent in? Because we all have to do that. Or I don't think I can do this case without putting 2 stents in, because we're all thinking that's the case. What we're debating here is whether in a patient where you've stented the left main into LAD, and the circ is a big vessel, it doesn't look quite right. Do you feel obliged to put a second stent in a way that you wouldn't normally if it was just a diagonal? Is it because it's the ostium of the circ? Do you feel that you need to do more than you normally would? Can I just take that round the panel? What would you normally do? Would you FFR it? Would you IVUS it? Or would you just say, look, it's the proximal circ, I'm going to put another stent in?
I think it depends on what is in the proximal circumflex and how much plaque shift do you have. I think the idea of assessing then the ostium, the degree of plaque shift or degree of compromise with FFR or intravascular imaging technology is a good one, because you're trading 2 different problems, maybe some compromise of flow versus turbulent flow due to extra metallic struts, NASB struts, which could be the nidus for stent thrombosis.
So you've got it just looks a bit nipped. It was okay to begin with, it now just looks a bit nipped. In your lab, what would be your first step? Would it be, I'm going to wire it and FFR it? Would it be a wire it, I'm going to balloon it? Would it be, I'm wiring and IVUS it? What would be what's your usual approach to that?
Probably wire and OCT it.
Wire and OCT. You pass the microphone along. Can I ask you the same question?
Yeah, to keep it simple, I would, obviously I would wire it. I would do a Kismas probably to open up the struts and make sure it's optimized, and then do imaging. So I would do either IVUS or OCT.
And you're looking for, what with the OCT, is it the area you're going to look at, or is it disruption, or are you looking at the amount of plaque? What are the things that you're going to look at with the imaging which informs that decision as to whether that second stent's got to go in?
I think it's a combination. You want to see if there's any disruption, if there's any dissection, is it smooth, and is the area and flow fine? If you're still worried, you'll do an FFR or IFR to see if there's any significance.
So it sounds as if your tendency would be, I don't really want to put a second stent in unless I have to, even though this is the circ, even though it's dominant?
Yeah, I mean, if you've decided you're going to go with a single stent strategy, then you've got to stick to your guns and really find a reason why you should put in a second stent. The problem always arises is if, my policy is if I'm thinking that it needs 2 stents from the beginning, I will go from 2 stent strategy. If I decide on a 1 stent strategy, I'll try and keep to 1 stent strategy.
Got to hang
unless
tough.
I'm proved, yeah.
I think we all kind of feel that we get a better result with a 2 stent strategy if we do it from the beginning. We certainly feel better about ourselves because of that hang tough feeling that, have I kind of given up a bit? Angela, I'm going to turn it around a bit, if I may. I'm going to ask you about a case where you've got a big left main, it's a big dominant circ, there's no plaque in the LAD. You're going to stent into the circ, and the LAD looks okay. Are you going to leave that? Or would you feel, because it's the LAD, you should put a second stent into it?
No.
So
I would kiss, I think, because I would feel happier that the stent struts were open towards the LAD, and I would undoubtedly pot and ensure that I would use imaging to make sure that the result in the circumflex was good.
Push you then.
My worry
Yeah.
is that the angle around the circumflex is usually greater, so I think you have to do a lot of lesion preparation before you put that stent in.
So the 101, you've treated with a single stent, and you're going to be sure the LAD is okay. I'm going to turn that around. It's the circ is dominant. It looks like a 110. Do you feel the same about the circ, or is it just the circ? I'm not so worried about it. I'm going to treat the LAD as different to the circ, even though the circ is dominant and large in this vessel.
No, my philosophy is very similar. So if I'm doing a provisional type strategy, I'm very much an FFR person. Because I think you can get caught out, particularly with IVUS imaging, where if you've stented from LAD to left main and your circumflex is nipped, I think if you do a pullback with an IVUS, you can get caught out because the IVUS pullback is not coaxial with the angle. And I think you can think that the lumen of the ostium is actually much bigger than it is. So I would always use a physiological measurement in that situation. So
that was fantastic, thank you. Whilst we're hearing these last two answers, the questions are on the app there, so please start filling them in. Thank you.
First of all, we have to have in mind that such a lesion like isolated distal left main almost doesn't exist. There is a very nice Spanish IVUS control trial showing that in most of the cases, even in angiographically clear circle LAD, they are involved into the lesion. And we have to have always in mind that probably we have to switch from provisional strategy to two-stent strategy. So in all our cases, the initial strategy is the provisional, but we are trying to have in mind that we can switch from one-stent to two-stent strategy, because in very rare cases, we are joking, the circ is a side branch of the LAD, but this is really in very rare cases. It's a too big responsibility to name the circ side branch, because in many cases the circ is a huge territory, having in mind that is supplying the territory about mitral regurg increase in case of ischemia. So it's quite important. I think that in the future we are going to need probably a dedicated left main stent that is facilitating very fast and easy access to the side branch, LAD or circ. It doesn't matter.
I mean, I think we are slightly hoisted by history as well, because if we go back quite a long way, we were terrified if we stented the LAD first, that we couldn't get a stent into the circ, that these stiff stents wouldn't go around the corner. It's not like that anymore, is it? You know, things have changed. A lot of the things that we were kind of brought up with is we kind of took left main on to begin with, and now kind of not like that a lot. And we can be a little bit more relaxed about it, I think, but we've still got that whittling away in the back of our head. Oh, will you get a stent round if you have to? Well, you can usually, can't you? I mean, it really isn't a challenge. So your view on this? Big circ, small lesion at the ostium, what do you feel?
I think, as Olivier mentioned, I would favor the physiological importance of the circ, and then consider it as the main vessel probably, and to assess the potential indication of a provisional stent on the second branch, what we could call the side. And to be totally honest, it's true that the FFR or OCT are very seducing tools, but we currently don't use as on routine practice in our labs.
So if you're voting on the vote, which one were you going to vote for? Let's see whether you won. It was option one, 2 stents are always required. Option 2, 2 stents usually desirable. So I use 2 stents more readily in the left main, but not always. Or 3, it's just another bifurcation. I do what I'm supposed to do. Results up, please. So I use 2 stents when I have to, same as any other bifurcation. Has come out top, which kind of is interesting, isn't it? Because it kind of means that we are perhaps confident that we can get that stent into the circ, and that ultimately we shouldn't be kind of emotionally browbeaten into perhaps feeling we have to put a stent into the circ if it doesn't look quite right. Please.
Sorry, just a comment or a question that maybe we can have a look at is that the dilemma that I have, and that's why when I decide on a 2-stent strategy, I decide from the beginning, is that once you decide you're going to treat everything provisional, then your 2-stent strategy is going to be 99% T or TM protrusion. Whereas there have been no real studies done to actually compare TM protrusion with the DK crush. And it appears to be that if you're going to do a 2-stent strategy, your DK crush should be your treatment of choice. So by going provisional, you're limiting yourself in terms of your 2-stent strategy. And that's why you have to decide at the beginning, is it 2 or are you going to go
How much imaging do you do before you start?
Well, most of my left mains, I'm going to do imaging to, before I start to actually make that decision.
That's a logical extension of what you said, isn't it? Is that ultimately, if we don't image before we start, then what do you know? And I think what we do know about the left main is you often just can't tell. So that if you embark on a single stent, when actually you would have got a better result, as you say, with a different technique, more fool you, frankly. That's great. Okay, we'll move on to the next topic, and then we'll take, because there's another vote, and we've got to hopefully get some audience questions on that. So the next topic is left main optimization, how to use imaging.
Okay, so this is really taken directly from the consensus document published earlier on this year following the meeting from last year. So let's look at intravascular imaging. And I think we have consensus that the angiographic assessment has several limitations. And therefore, the recommendation is to have a low threshold for the use of IVUS or OCT. And I think what's really pertinent to the left main stem is that we know that we really can't move the C-arm into an appropriate angle to look at the circumflex ostium. And that's a problem in around 40% of cases. So we already know when we look at our angiography compared to, say, CT scanning, we physically can't get the machine into the right angle. And we have consensus, of course. Imaging provides crucial information to help us in terms of planning our procedure. There's consensus generally about the difference between the two modalities. I think we accept that OCT provides superior images. It's able to give us information such as wire position, where we've crossed through the side of the stent struts, and gives us much more information about the side branch ostium as opposed to IVUS. But clearly, one of the limitations of OCT is that it's not usually possible to give us assessment of the ostium of the left main. So what did we say on the consensus? Well, one of the consensus is that we feel pullback should be made from both the main vessel and the side branch. We also said in terms of consensus that we would not recommend recrossing a jailed side branch with IVUS or OCT because it can potentially distort, disrupt, or even damage the stent. And what about the left main stem? Specifically for the left main stem, we stated that IVUS is recommended for left main bifurcation treatment. OCT may be used with the provision that aorto-ostial assessment is often not possible. So that's our current status.
Dr. Leguto, thank you very much. It's going to tell us that IVUS of the left main and LED, treating the left main is not necessarily, we don't necessarily need to use imaging.
Thanks for the invitation, and it's my pleasure to be here again at the Bifurcation Club meeting. So I would talk about the old-fashioned IVUS because I still believe that it's valid for at least for left main cases. This is the summary of different recommendations that were published by European Bifurcation Club for the last years, and I still believe, and also those presented before, summarized in the 11th consensus, that most of them are valid. However, I believe that we need also some upgrade because the data has changed. First, of course, IVUS to use a severity and optimized treatment of unprotected left main lesions is now supported by European guidelines with the 2A class indication and the level of evidence B. And this was mostly driven by the main compare registry data showing the mortality benefit 3 years after IVUS-guided left main stenting in comparison to angio-guided. But now we have more data, and the most important are published by Jose Maria de la Torre Hernandez, and this is the meta-analysis of 4 trials showing us again that with IVUS guidance for elective left main PCI, we can decrease the risk of MACE. And what is very important, it is not mostly driven by the reduction of target lesion vascularization, but the reduction of death and MI. And the most important difference we see for the distal left main bifurcation, which is treated with 2 stents. So the new EBC consensus proposition from my side is that IVUS may be of particular value and is recommended for distal left main bifurcation treatment. It's true, but in my opinion, in case of complex stent strategy or suspected stent failure, IVUS-guided stent optimization should be just the standard of care for unprotected left main PCI. And this is maybe a good confirmation. This patient came to our CAD lab just a few weeks ago, and he was admitted with NSTEMI just 5 days after previous elective PCI, which was done with angio guidance. On angio, we see some under expansion of the stent in the proximal side, but what we see on IVUS is much more horrible, because then we see all the problems that we have when we guide our left main stenting with angiography only. In the distal left main, we see this huge malapposition. We don't even need OCT to see it clearly. And this left main was stented with 2 stents. I don't know why, and I don't know how, but what we see here is some crushing of the stents, but everything becomes clear if you go more proximal. And this, you see the one stent which is protruding into the aorta, but the probe is going out of the stent and coming into another stent. So probably they implanted the first stent, then lost the wire position, rewired, but going out of the stent or through the stent straps, the first stent which was implanted, and then implanted another stent. So everything in one patient, all the complications that we can have during left main stenting procedure. And what is important, we see more and more patients coming back after successful left main stenting procedure with some protrusion of the stent into the aorta, and then it's very difficult sometimes to engage the catheter, and even more difficult to go with the wires and balloons and stents if you need to treat subsequently LAD or circ. So I believe that another good recommendation is that the evaluation of wire position may be of particular importance whenever a patient comes back after left main PCI stenting for subsequent left coronary artery interventions. And for this indication, OCT is not useful because we are not able to see what happens just in the very proximal part of the left main with OCT. And finally, but I believe also important, European guidelines support the performance of elective complex procedures by experienced operators in sufficiently equipped centers. But according to non-emergency left main PCI, I believe that they should be performed by adequately experienced operators at centers that have access to intravascular imaging. Even if we don't agree that every left main PCI should be done with IVUS guided, at least those devices should be available in the CAD lab on top of rotablation, circulatory support. And what is also not only based on this one case, because we have much more such cases with under-expanded stents implanted at the QDMI in cardiogenic shock. So I believe that we should also think about delayed IVUS-guided stent optimization, which should be considered in all patients after emergency angio-guided left main PCI. It doesn't mean that all the patients should be checked with IVUS, but if operator is not really sure about the optimal stent deployment, if the final stent diameter was below 4.0, I believe that it is a good time to go back in few days to the CAD lab and to check the result with IVUS and or OCT and optimize the result. Thank you very much.
So we've heard a strong case for the use of IVUS, a lot of historical data there, a lot of integration of clinical messages with IVUS imaging.
Think back of all the sessions we have had today on OCT-guided intervention in bifurcations and also in left main, because they quite form the message that we are about to vote about now. I think it's also the sum of all the nice things you can optimize by OCT that does it. So I'll just talk you through again some of these items here, just to bring it up, as we don't have the clinical outcome evidence yet by OCT guiding, but I think we can do better than with IVUS, except that we cannot see the ostium of the left main. But I think also IVUS has several limitations that way due to the oblique wire positions. So if we consider that we have pre-dilated or just advanced a OCT wire, we can use it for checking the pre-dilatation very carefully. We can use it for sizing stents, sizing the pot balloon, and detecting the delivery route to check if we can actually advance our devices, especially with bioresorbable stents. In a case like this, it's recording from the circ towards the left main. Here in the ostium of the circ, we have a minimum diameter of 1.45 and will not be able to advance one of the new scaffolds. it's also often told that we cannot use OCT in diffuse disease, but we can almost always assess a good reference diameter by various tricks we don't have time for now. We can also get a good planning of our pot, making sure that there's actually room for our pot balloon in the left main when we're treating here. So it has to make sure that the stent extends so we can accommodate the pot balloon, especially in diffuse disease, not to inflict its dissections. So we always hear that we have a range issue with OCT, and I think the biggest issue that we have is that one of the vendors have a 7 millimeter range as their default. I have visited 33 centers within the last 2 years, and 2/3 of them say we cannot use left main because it looks like this, using left main. But they just need to know this button, as all of you know, change to 10 millimeters, and now you can use OCT in 95% of your cases, as has also been shown in the trophy trial. So if you go for your second pullback after you have implanted your stent, you have done pot and rewiring, you can check for lesion coverage, and it's extremely important, even though you sized your stent carefully, still we know that it's a major predictor of TLR if you have uncovered lesion with large lipid plaques in the edges. That's been firmly shown now. We know that expansion is a predictor of both TLR and stent thrombosis, and OCT is just a very neat tool, as it is now in a case like this, again from the left main to circ here. We can just have one marker assessed placed at the stent edge here, and we can just move this marker at all the segments, and every time we drag the marker, we can see what is the minimal luminal area all the way down. So it's very neat and very efficient to get an image if there's a detection of underexpansion. We tend to correct malposition if we can, especially in the fragile patients, because we know the more malposition, they will take longer time to heal. And so if you need to stop dual antiplate at an early time point, they might have a bigger risk. Further on, we also have the risk of abdominal rewiring. We have seen so many pictures of this today about optimal distal rewiring. As you can see here, we actually even distal to the bifurcation as it is indicated here. We couldn't advance our balloons. So if you go too extreme distal, you can also have issues. But you can use OCT again to check why do my procedure not progress. And then this is quite important that you rule out accidental abdominal rewiring also. There's a highest risk is in actually the left main because of the oblique position of your guiding catheter. You will advance it towards one of the sides here, and you can get the result like this, where you cross the stent, you can see immediate thrombus buildup, and again here. And another case here, where culotte stenting, and you can see we've got abdominal rewiring here, and when the patient was back in the cath lab with stent thrombosis, we saw that the stent was crushed and collapsed here in this proximal end here, again due to abdominal rewiring. We see here, we can follow by IVUS. If we can follow wire positions, we can see the IVUS wire. It's quite difficult also due to the light in here, but we can actually follow the wire here, extending into the ostium. This is the final pullback, but it's much more easy to see here that we can follow this exact same place. We can follow the guide wire. We can also see that ostium still has some nipping here, which was not evident on the angio. We know that in 40% of cases, you will not be able to put your angio in the position where you can actually see this. So in your third and final pullback, sometimes you need to have more. If you have more rewirings, you will check again all the lesion coverage, expansion, and position very fast and quick, and then you will focus on the side branch ostium to make sure that it's optimal. You can do all kinds. You can go very much in details, but you can also do very rough measurements that are actually quite accurate, especially in the left main due to the almost 90% angulation. We use this one, the Kang rule of 5, applying that also to OCT. And we know from actually Gary Mintz's group, published by Oviedo, that ostial circ assessment using a main vessel IVUS pullback is only limited reliable. So, okay, it was just blanking. Thank you. So.
Niels, that was great. Get an expert to talk about what he's enthusiastic about, and he will talk. So that was fantastic. Thank you very much indeed. very compelling. So what I think we want to talk about today in particular is this question about how we consider imaging, how important we feel imaging is in an elective patient. If I'm treating, I'll go this way around if I may, if I'm treating an elective patient with a left main, I don't mind whether you do IVUS or OCT, but do you have to use imaging? Or would you not only use imaging on a Monday and a Thursday? Because actually you're busy on a Tuesday and you haven't got time.
Matter of being busy or not, as it was mentioned, I think in most of the time, if the LAD and the circ are not diffusely diseased and we can have a clear angiographic reference diameter, we extrapolate the diameter of the left main and work from the angiographic tools, knowing what we've learned from intravascular imaging, either IVUS or OCT. And in some troubleshooting situations, like a difficulty for rewiring or uncertainties on the diameters of the circ and the LAD, in such situation we use intravascular imaging.
But specifically?
Yeah. Another comment I would like to make about the importance of intravascular imaging, because we've seen in previous sessions beautiful examples from experienced operators of left main stenting, is about whether to decide to cover the left main ostium or not. And sometimes with angiography it can be really, really difficult to appreciate if it's necessary, and I think it can be also a valuable option to use intravascular imaging to decide for that one.
It's often very difficult to know whether you have done, and certainly the feedback that you get from actually, and particularly for the right coronary ostium, to know whether you really covered it, particularly when you're learning, is absolutely essential, isn't it? But specifically, I'm doing a left main in an elective case. Is the IVUS catheter or the OCT catheter always open or usually open?
Let's be down to earth. We saw in the trials how important the imaging, IVUS or OCT, to improve the results, especially the late results. In our daily practice, we are using mainly for sizing, for precising lengths, for precising secondary dissection after kissing balloon inflation, in order to decide to stay on provisional or to add a second stent, so more practical. And because of that, in our case, in my cath lab, we are using mainly IVUS to optimize the results of the primary procedure, and a little more OCT into the follow-up period to show malposition or uncoverage of struts in order to optimize the late results.
Great. Angela, you're younger than me. Are you OCT friendly? I get a feeling that IVUS is perhaps a generational thing. And as an old man, I like IVUS pictures. I know what I'm looking at. I'm doing a left main. I need to have the IVUS machine. It makes me feel comfortable. But you're a young lady.
I'm not that young, honest, really. It's hair dye. No, I mean, I think there's a difference here in that we're trying to get a message out to the general community.
Good, yeah.
Left mains are important.
Right.
And I think that case that Dr. Legutko showed is absolutely critical, because it may have looked good angiographically, but they made an absolute pig's ear of the result.
Right.
And that could easily have ended up with death of the patient. And the problem is that unless you do a left main really well, that ultimately could be the result. And you don't know what you're dealing with angiographically. So I think for the vast majority of operators, for the vast majority of patients with left main disease, they should have imaging.
So I was going to say, that's right, because in 4 weeks' time, we'll be in a position where there'll be randomized data of interventional therapy with stents against bypass surgery. But in truth, it's interventional therapy in 35, 40 centers, because actually most of the trials were done in, most of them recruited in 15 or 20 centers, by 15, maybe let's say 60 operators. We need to be careful how that rolls out, potentially, depending on what the results show.
Exactly. It needs to be somebody who is an experienced operator that basically knows what they're doing, because whatever they do, they have to do it well. So the question as to which modality of imaging you use, again, goes back to what you're most familiar with. Of course, OCT is fantastic for bifurcation experts who can look at the OCT, understand the images, do the wire crossing in the right place, but whether that's applicable to your average interventionist, I suspect that's going a little bit one step too far. So I think you need to use the imaging modality that you best understand, but I think you should image.
So if you can't do IVUS and you can't do OCT, don't do my left main. Is that what we're saying?
But if the patient can wait, then you can refer to someone that's got the imaging, preferably.
Well, that's a different situation, isn't it?
Yeah. So, but I think that's the main thing. You know, when it comes to IVUS and OCT, just to make a comment, you know, a lot of these patients are elderly, they've got multivessel disease, but over and above that, they've got renal dysfunction. And my problem with OCT is the amount of contrast that we're giving. So unless you can give another agent and you're not giving contrast, be very careful in using OCT, because every time you inject and you're giving 50, 60 mils, we're saying give 3 runs, and if you don't get a perfect picture, you're going to do another 3. So that's already 300 mils before you've actually even considered doing any other runs. So I think, you know, look at the patient as a whole, and don't just say, I'm an OCT or IVUS man.
Nils won't be allowed me to let you say to 60 mils. He's not going to take 60, 10 maybe. And with collocation, you're going to get a picture as well. But for us, it's OCT for you, or IVUS for you, or depends on the circumstance?
OCT I can see better with OCT, and I think what Robert Jan showed as a case, so one of the ideal main cases, yeah, you guys are experts, but you missed a couple of malapose struts, more than a couple with IVUS, and I don't think you would have done it with OCT. So,
well, that's a great message, which is it's all well and good to do the imaging, but you've got to look at the pictures. And one of the things we're all a bit lazy at is looking at the pictures. And one of the things, again, as an IVUS person who grew up with it, I look at it as I do it, and then I don't look at it again. At least with IVUS, with OCT, you've got to go back and kind of scrutinize it and go back and back and back. And I think there is perhaps some learning in that. And I think actually we are slightly complacent about the way in which we observe the IVUS and perhaps the way in which we teach it. That would be my personal view. So let's look at how the vote worked out. Can we see the answers to the questions? No. Oh, here we go. So I always use imaging, IVUS or OCT. It's essential, and I criticize those that don't, was the most popular answer when treating a 2-stent left main bifurcation in an elective case. And actually, that's a pretty strong vindication of this expert group for imaging, taking it forward with regard to how we try and spread the message of imaging to optimize our results. We're slightly behind, so I'll close the session with that. Thank you very much for the panel. Thank you for your voting, and we'll move on to the next session, which is case session, tips and tricks, complications. Thank you very much. Thanks, guys.